common one is spontaneous bacterial peritonitis, the SBP. But all of these infections may present as non-specific signs, which would be a difficulty for diagnosing these patients at the very first phase of the disease. Also, the diagnosis of infection, the gold standard, is still bacterial culture, but it's time-consuming. It takes at least 24 hours for a blood culture to have its results. So finding a laboratory diagnosis for infection is a vital problem. The author also reviewed some characteristics of procalcitonin. It has short induction time after bacterial stimulation, and thus it can be used for diagnosis, severity assessment, prognosis, prediction for bacterial infection. But yes, and that's the point, that no study aimed for the detection of procalcitonin levels in liver failure patients yet. So this is what this meta-analysis is about. The author is going to conduct the meta-analysis to find out the solution for this problem. So the authors searched the databases from these listed above and using the methods like this, like the presentations. Their inclusion criteria is, first of all, these studies should aim to assess the diagnostic values of procalcitonins for bacterial infections in liver failure patients. And secondly, these studies should aim to limit it to patients that are adults. And thirdly, they should compare patients with liver failure with infection and without infection. And fourth, the last one is about the diagnostic criteria for infection listed above. There are also some of the exclusion criteria, which is like animal experiments and like incomplete data and etc. The statistical analysis part, the authors uses Kuan-Fu for quality evaluation and using the data software. So as for the results, the author found 6 articles with like 400-ish patients with infection and without infection. Here is the characteristics of 6 included studies. Let's see. Oh, I don't think I can point on my screen. But yes, as we look onto the different categories, we can see that these 6 articles included different etiologies for liver failure with different diagnosis also. And also, these 6 studies have different cutoff values for procalcitonin, different sites of infection. And also, these articles are published in the recent decade, which is quite new, actually. And as for the quality evaluation parts, there are 3 studies stating that their patients did not receive the same reference standard. And thus, there are like 3 out of 6, which is like half of this having kind of the bias in the flow and timing parts. But overall, the qualities are fair and it is good for this. And here is the forest plot of the sensitivity and the specificity of these 6 studies. Well, the pooled sensitivity is about 0.77. I hope that you found this number nicely on this presentation, which is quite small. And the pooled specificity of 0.76. Also, as we look to the p-values of both of them, which is 0, and the I-squared, which is like 94 and like 80, we could find out that there are significant differences and heterogeneities among these six studies in the sensitivity and specificity parts. Also, as we look to the likelihood ratios, including positive ones and negative ones, and also the diagnostic odds ratios of these 6 studies, there are still significant heterogeneities, which is presented as the I-squared. This is about So one of the most common causes of heterogeneity may be due to sampling bias. So the author also conducted their subgroup analysis and tried to resolve the heterogeneity, but in vain, as the author conducted different subgroups like age, like etiologies of liver failure, different infection size, and different procalcitonin cutoffs, but all cannot resolve this kind of heterogeneity among these 6 studies. So these concludes the results part. And as for the discussion, first of all, the author discussed about the relationship between procalcitonin and liver disease. Well, actually, procalcitonin is synthesized by the liver. So logically speaking, the more hepatocytes damaged, there should be the less procalcitonin levels found in the bloodstream because there are there are less sources producing procalcitonins. But however, there are some of the studies the author found that shows the more severe the liver disease is, and actually the higher the procalcitonin levels. That may be due to 2 reasons. The first of all is about the damaged intestinal barriers. We know that liver cirrhosis patients, they've got more susceptible to bacterial translocations, thus more endotoxins released in the bloodstream and more stimulus for procalcitonin release. And the second reason for this may be due to more DAM, as mentioned before, and thus more inflammation responses for the overall condition. Well, despite the either negative or positive correlations between procalcitonin levels and liver diseases, procalcitonin still stands a diagnostic significance in some of the studies. Well, one of the studies found no difference of procalcitonin and CRP levels between patients with liver failure and with liver cirrhosis and without liver cirrhosis, which both all have infections on these patients. And the second study, they found out that in patients with alcoholic liver cirrhosis, procalcitonin still can help identify patients with infection and has better diagnostic accuracy than those of CRP, C-reactive proteins. So the author here states that they found out procalcitonin is of median diagnostic values in distinguishing bacterial infection in liver failure patients with a sensitivity and specificity of about 0.76, 77, and the diagnostic odds ratio of about 10.6 and the error under curve of 0.8. And then last but not least is about the limitation for this study, which is the author mainly addresses the heterogeneity. They came up with some of the probably resolutions for the heterogeneity. It may be due to the different liver disease etiologies, severities, different cutoffs, or even more basically, different testing technologies, labs, settings that differs from hospital to hospital. So, well, however, despite all those heterogeneities and those limitations, the author still finds a fairly diagnostic accuracies for procalcitonin in patients with liver failure. Okay, and this sums up all of my presentation today, and I'm welcome for any questions and comments for this.
Thanks, Dr. Lin, for briefly summarize the study for us. The reason I picked this study for him to share has several, some of the both educational purpose and for our team development purpose. So the first one is to let you know that the procalcitonin is already being studied for like decades, as Dr. Lin showed you, and there are tons of meta-analysis trying to figure out what's the perfect timing for us to use this biomarker in clinical setting. So this study is published in Hindawi group. Although this journal is relatively new, I think still it has a very decent impact factor in terms of citation, etc. So this is interesting because this is a old topic, but once you have some new idea, you can still publish in some decent journal. And the other thing is because we are also doing the microRNA project, so this is also a diagnostic study. I think it's good timing for us to check the diagnostic accuracy type of meta-analysis. As Dr. Lin pointed out, I know there are some many interesting topics that we could discuss, but I'm going to save some time for maybe some of the medical students in our team. I think you're welcome to raise some question first, and I do have something to comment later. So any question that you might have?
I'm kind of curious about their definition for liver failure, because I feel like when we are seeing patients with liver disease, like liver cirrhosis, basically patients have different severity of liver cirrhosis or liver failure. So, and sometimes people got liver failure with kidney failure, like hepatic renal syndrome. I feel like the whole metabolism will be different. So when they do this meta-analysis, I would say when they do the study from different level of liver failure, do they have the clear like definition for that, or for example, like everybody's kind of like severe liver failure, or some people like maybe just mild, some people is kind of more severe, some people just have liver failure only, or just liver cirrhosis, or they have the combined renal dysfunction.
Yes, thanks for Dr. Zhou for this question. And as this table actually suggests, they included patients with liver failure with the diagnosis. This is like this, with like different criteria and like prolonged prothrombin times, like INRs and like total bilirubins, and even like with syndromes with hepatic encephalopathies. Well, however, Dr. Chu also addresses that patients would frequently come with like combined problems, but this article did not stated that they only included patients with liver failure, and they didn't address about the other like underlyings and like hypertension, diabetes, and even kidney failures in these patients. So yes, I think this is going to be a good problem in investigating about how these different organ systems, their disease would affect the overall clinical presentations of these patients. But this study did not clearly state about this parts the detailed information.
And why? So why the what are the results? I mean, I think that there's a big variation between different studies. I mean, for the either sensitivity or specificity. You can see from like 40-something% to 90%. Yeah. So is it because of the definition of liver failure, or the definition for bacterial infections, or what's the problem from there?
Yes, as for the heterogeneity, the author only finds out that it's not due to like different etiologies, which they addresses on acute on chronic and non-acute on chronic liver failures. But actually, there are still other different etiologies for liver failure, I think. And this heterogeneity is also not resolved by age and size, which they only conducted in sepsis and non-sepsis. They didn't conduct like pneumonia, non-pneumonia, SBP or non-SBPs. So I think that, as the author would suggest, the heterogeneity may be due to other possible factors, but not these factors listed here, like age with the cutoff of 50, like the etiology with a acute on chronic one or non-acute on chronic ones of liver failures. But they didn't discuss furthermore, like, and different etiologies and different sites of infections and so on. So yes, I think they actually contributed this to the the nature of liver diseases, which are like with many different kinds of aspects and different kinds of severities. So this is why there are kind of like different between these 6 studies.
Yeah, I think Dr. Ching can give us more teaching point, but I think from my standpoint, if I'm seeing these articles, like what you said, I think I'm kind of pretty I kind of hesitate to use Procal to do the early diagnosis, just based on the result.
Yeah, I have to applaud to the authors for their efforts already been doing so many different subgroup analysis, like like what you just said, because usually people will stop after they figure out that the heterogeneity, they go to the random effect model and they say that's the fix for all, and that's not true. As you can find in this slides, the heterogeneity is only found to be probably acceptable for a cutoff more than 1 microgram per mil. So I would say for the rest of the subgroup, we still have many other possible confounder for us to figure out why the studies are so different. For a study like what we are trying to do for the local therapy, if we have more than 20 or 30 articles available, maybe we can do a meta-regression, which I think they try, but still the meta-regression suffer from this small sample size issue. So in the optimized world, if we can have as many studies as possible, and we can find a subgroup with homogeneous, both statistical homogeneity and clinical homogeneity, then we could have more confident results. And I think that's a downside for a clinician, but that's actually the niche for a researcher, which means we still have some space to both update and optimize the future meta-analysis for procalcitonin. But I agree with Eric. At this moment, I personally wouldn't, routinely use procalcitonin to screen for both infection or sepsis, especially in this specific systematic review and meta-analysis. Although they stated their reference standard is perfect, but I don't agree with that because, they have many different kinds of reference standard. How could you just combine sepsis 3 with, culture-proof urinary tract infection? That's totally different story. And I would say that's a good beginning for us, to start with. This article is quite encouraging because even this could be published in this kind of journal. So I'll just use this one as one of the examples that we could just quickly do in the coming 1 or 2 years. So that's also one of the purpose I want to share with you this day.
Yeah, I think in general I like the idea. I like the idea about this meta-analysis, or even the whole study. Like what we said, when we do the study, we have to get a clear definition for everything. Like Dr. Chen said, how we define infection, how you define liver failure. It's kind of important because it will affect your result. I don't know if they because I think the sample size is pretty small. So when they did a lot of like subgroup analysis, I don't even know if they have enough power for that. But I think it kind of gives the ideas like how people do their meta-analysis, and when we do our meta-analysis, it's kind of very important for us to understand how you read articles and how you get the data.
Eric also raised another good point, because if you look at the number of the studies that this systematic review and meta-analysis included, we only have like 6 studies. But if you look at the number, the sample size, every study included, we could have like maybe several hundreds participants that will be available. Another strategy to try is to contact the author to get individual data. Then we could just play around with the raw data with individual data analysis. So that's another commonly used strategy to increase your sample size from 6 to several hundred. So that's also doable. Although I would say many researchers has the comments in terms of their success rates. The probability that the author will respond to you is about 1/3 or 1/4. If you are only an independent researcher, say if we are collaborating with maybe some pharmaceuticals such as Roche or somebody who's doing consensus study, which is another story that I'm going to tell you later. We could just it's very possible that the pharmaceutical could contact those researchers and get the results. But the downside is if you are collaborating with the pharmaceutical, sometimes you lose the independence, the power or something you can just try. Because I don't have time to illustrate that, but in one of the study supported by Roche, they contact, I remember it's 400 center, in which the oseltamivir, the Tamiflu, has been tested in those centers. Only 80 of them, 1/5 of them, respond, and some even refuse to participate. So that's something that we still need to play around with the pharmaceuticals. But the story I'm going to tell you is in Taiwan now we are having a consensus meeting, or having a task force to investigate procalcitonin, to see, like, for what we learned from this study is that we are not sure about the diagnostic accuracy in the liver failure patient. But what will be written in the consensus, in the guideline, I'm not sure, but what I want to do is to take the chance, take the advantage of what we are doing, and maybe we can figure out some topic for us to do later in the coming years. Just want to let you know that. So any question from the students? I know that Dr. Lin actually skipped some of the statistical part. So for data, they use the SROC method, which is not the perfect one because we have different, I would say, 2 mainstay for the diagnostic study of meta-analysis. One is to go to the ROC method, the other is the bivariate method, but I don't think we have time for this month. So maybe next month or next year, I'm going to share with you more in terms of the statistical method for both interventional study and for diagnostic study. Just stay tuned.
Yeah, I had a quick question about the cutoffs. How did each study determine the cutoffs, and then why are the cutoffs, and what I would assume are pretty wide variable cutoffs?
Well, this study only states about the cutoff values of each different studies, And I personally guess that they set this cutoff for their optimal sensitivity and specificity, actually. So that is why each study had on the foundation of different patient selections and like different size infections and so on. So for these kind of different patient groups, they derived each of them a optimal cutoff for each of their patient groups. So yeah, I think that's why they've got different cutoffs, because they can have their best sensitivity and specificity in each of their own studies.
Gotcha. So more I guess end goal oriented than scientifically. That's the cutoff that they decided.
Well, I don't think that this study actually specifies other information about this.
Usually, people use some index, such as Uden index, to determine their best cutoff. So that's a trade-off between sensitivity and specificity. So if you pay attention on the balance between the sensitivity and specificity, you can see like the second study, they have 0.6 sensitivity, 0.3 specificity, and their cutoff is kind of weird, like 1.62. So they probably use the Uden index, which is actually a good index for early, in the development of biomarkers. But later on, you have to figure out some easier cutoff for people to use, such as 1 or 0.5. But none of the sections use the easy cutoff. Which means they actually play around with the cutoffs to decide the best cutoff for the purpose, say, a good enough sensitivity or a good enough specificity. So that's also a source of heterogeneity, which I think this specific study actually tested for the correlation between the cutoff and the performance of the study, which is the common practice for diagnostic meta-analysis. So again, this is another source for heterogeneity, good observation. Always pay attention on the cutoff and always test the correlation between the cutoff and the performance. But we don't have a remedy for this. We can also only hope in the future, maybe some researcher like us, to find out the individual data and to use the raw data to find the appropriate cutoff for all of the participants, including these all studies. Then I would say that that's the time we can just call it the best cutoff has been found. Otherwise, I think this also indicates that researchers we are still uncertain. We are not sure about the best cutoff for this kind of specific study population. Good observation.
Thanks for the question from Dr. Zhou and comments from Dr. Chen, because I didn't dig that much into this.
I thought the different cutoffs from different modules.
Yeah, that also could be true, because now many pharmaceutical can test for procalcitonin, like Roche is the very early one, but like BD or other type of machine, they have their own recommended cutoff. So again, in the real world, we don't have a luxury to test every machine, but that's also doable project. If you want to test different machine, like compare different machine, different institute, that's also doable project. Just call them, because sometimes the pharmaceutical company, they are enthusiastic to promote their product. You can just give them some waste specimen and ask them to test whether the difference will be depends on, like, say, the renal function, because we tested for the high sensitive troponin for Roche, BD. I don't remember the third pharmaceutical, but we can just try to see the influence of different assays. That's also doable. And that's also the next step if you were interested.
Yeah, it's interesting because you just mentioned high sensitive troponin, because I was thinking, So when we have the patient with renal failure, sometimes we will see the false elevation from high sensitive troponin.
Yeah.
So I want to know if we can do a meta-analysis for that, just like for the high sensitive troponin, how's the diagnostic accuracy for patient present with chest pain, also with end-stage renal disease, or even like under dialysis. I don't know if there are enough like study to do a meta-analysis, but it sounds like a good topic for that.
Yeah, I agree with you. Actually, one of our residents is preparing a manuscript for this kind of subgroup analysis from just for data collected from our institute. Although this number will be smaller, but I can just touch base with him briefly to see how many studies are published recently, and that's a good question because in our own database we found that the high sensitive troponin T instead of high sensitive troponin I are more prone to the confounding effect from the renal failure. So that's a good point, and I think we can just go back to discuss the possibility to initiate another systematic review in this team. That's a good question.
Okay, good. So I like this idea. When we discuss one article, so sometimes we can have like different idea for future research, and we try to learn from different study, either from their idea or from their statistical method, and we try to learn from the structure of the meta-analysis. So when we are doing our own meta-analysis, and we can usually point out the problem. Okay. Any question from our student?